Hello and welcome to another live stream, emergency questions and answers for families in ICU and intensive care at home. I'm your host, Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com. Now, before we go into today's questions, and I can already see that there's questions on the side here, what makes me qualified to host a show like this? So I'm a critical care nurse by background, and I've been working in critical care nursing for 25 years in 3 different countries, where I worked as a nurse manager for over 5 years and where I've been consulting and advocating for families in intensive care since 2013 here at intensivecarehotline.com. And I can very confidently say that we have saved many lives for our clients in intensive care, and you can verify that on our intensivecarehotline.com podcast section where we've done client interviews, and you can also verify it on our intensivecarehotline.com testimonial section. And like I said, we have saved many lives, and that is without any exaggeration whatsoever. And that's why I do one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. We also have a membership for families of critically ill patients in intensive care, where you have access to me and my team in the membership area and via email. And we answer all questions intensive care related there. And I'm also the founder and managing director of intensivecareathome.com. With Intensive Care at Home, we are sending our critical care nurses into the home, predominantly for long-term ventilation and tracheostomy, but also for home BiPAP, home CPAP without tracheostomy, tracheostomy without ventilation, but also for home TPN, home IV potassium, home IV magnesium infusions. We're doing central line, peak line, Hickman's line, as well as portacath management at home. We are also providing PEG tube and nasogastric tube management at home, ventilation weaning at home, as well as palliative care at home. With Intensive Care at Home, we are currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas. We are NDIS approved all around the country, DVA all around the country, iCare in New South Wales, NIISQ in Queensland, and TAC and WorkSafe in Victoria. We're also providing level 2 and level 3 NDI support coordination, and we're also providing TAC and WorkSafe case management in Victoria. So, without further ado, let's dive into today's questions. And also, like the video if you like the work that I'm doing, if you like the show that I'm doing here and my other videos that I'm putting out there. Like the video, subscribe to my YouTube channel, click the notification bell. Most importantly, share this video with your friends and families and leave your comments, of course, so I know what content to create. So let's start with some of the questions that are here from S. Ralsbury. But also, if you want to talk to me directly, then I can also encourage you to do so, besides leaving comments there. You can also connect with me live here on StreamYard, which I highly recommend because we can get to your answers much quicker rather than going through them via the chat pad. So, S. Ralsbury says, I have a 56-year-old male cousin who got pneumonia, now ARDS. He is in an induced coma on a rotating bed. What suggestions for optimal care? He's been on a ventilator for 3 weeks. He has no advance directive. The hospital is asking, should they do a DNR? They have been given a very grim outlook of his quality of life. If he survives, permanently paralyzed, full-time oxygen, relearning life skills, etc. Why would they say this? He's not brain damaged. He's in Oklahoma City in the US. Thank you so much for sharing that, S. Ralsbury. Let's just break this down step by step. It's not unusual that pneumonia develops into ARDS. ARDS stands for acute respiratory distress syndrome, also known as lung failure in more general terms. He's in an induced coma, no surprises there, in a rotating bed. Why would he be in an induced coma? He would be on a ventilator with a breathing tube, and it would be very difficult to ventilate him, because when you look at chest x-rays from ARDS patients, it's usually a complete whiteout, meaning the lungs are completely consolidated and there's barely any gas exchange going on, i.e. oxygen getting into the body and carbon dioxide leaving the body. So gas exchange is really impaired big time. So what are suggestions for optimal care? So one suggestion for optimal care is to potentially put him on oscillation ventilation. What oscillation ventilation means is it's sort of giving short intervals of breaths, very short, with a low tidal volume or lower tidal volume, but really fast. It sounds like a machine gun almost when you're ventilating someone with an oscillation ventilator, and that can be effective, right? But probably more so in this day and age, what's more effective is probably putting him on ECMO, right? VV ECMO, veno-venous ECMO. So ECMO basically is like a bypass machine. It's taking over the function of the lung, or it can take over the function of the lungs for a period of time, giving the lungs time to heal. Other suggestions to treat ARDS is to do nitric oxide therapy, to give nebulizers such as epoprostenol, to give sildenafil, also known as Viagra, for pulmonary hypertension, which often goes hand in hand with ARDS or lung failure, right? Other suggestions is steroids, right? Other suggestions is to give antibiotics, right? Or antivirals, depending on what ARDS infection is. So, for example, during COVID, a lot of patients ended up with ARDS, which was caused by a viral infection, i.e. COVID, right? So those are some suggestions, but especially since he's been ventilated now for 3 weeks and in an induced coma, I highly recommend maybe to put him on ECMO. Other suggestions are prone positioning, right? So what that means is putting a patient on their tummy, head down, to basically drain any secretions of the lungs, right? Which can also be very effective. And if that doesn't work, then definitely ECMO, right, as a next step. What also happens is when someone has a pneumonia or ARDS and they're lying on their back or even lying on their side all the time, not all areas of the lungs can be perfused, right? Because the lungs can't expand. If you're putting someone head down in a prone position, it's much more likely that all areas of the lungs can be perfused, right? Can be very effective. Now, you are also suggesting in your messages here, as Rollsbury, you're also saying that permanently parallel, that's the long-term outlook. What needs to happen when someone is moving into prone position, right? They need even higher levels of sedation and opiates, and they often need to be paralyzed chemically, which means they need to be paralyzed with medications so that they can actually tolerate lying on their tummy, head down, because that can be very taxing, right? Can be very disruptive for the body, for an already very sick body, right? So the other thing that needs to happen during ARDS is often a high PEEP. So what does PEEP mean? PEEP stands for positive end expiratory pressure. Basically stops the lungs from collapsing at the end of expiration during mechanical ventilation. And by giving a high PEEP, the lungs won't collapse, because if the lungs collapse during ARDS, when there is already minimized gas exchange going on, right, a high PEEP is very important, right? So let's recap treatment options for someone with ARDS. He's already in an induced coma. That's part of the treatment options, right? High oscillation, high frequency oscillation ventilation, ECMO, of course, prone position, nitric oxide, nebulizers such as ibuprostanol, steroids, antibiotics, antivirals, or antifungals, depending on the source of the infection, right? And then let time work. But I highly, highly recommend that ECMO is the way to go here, right? But not all ICUs have ECMO, even though the number of ICUs that have ECMO is definitely increasing, right? It's also good to hear that he is on a rotating bed, which means they can probably rotate him from side to side, with not much interference, right? With him not getting too unstable, because it's a bit more gentle than rolling someone manually with manpower, right? But there's still a very good chance that when you turn him, whether manually or with a rotating bed, that number one, he would be on high levels of FiO2, which means, the oxygen that he's getting through the ventilator would be, I argue, 50% or above, right? Most likely closer to the 100% mark, because once again, the gas exchange in the lungs is almost not there, right? Depending on the severity of the ARDS. But if your cousin has been ventilated now for 3 weeks and has not been woken up, then I argue it must be one of the more severe forms of ARDS, because 3 weeks in an induced coma without any progress, that's a long time. Now, you also haven't mentioned anything about a tracheostomy here, which further confirms my suspicion that, number one, he has a high FiO2 level, right? That's number one. And number two, he would be on a high PEEP, right? And if he is on a high PEEP and high FiO2 levels, he can't have a tracheostomy, even though he probably needs one to help him with weaning off the ventilator. It's sort of a catch-22 here. And the catch-22 is, let's just say he could have a tracheostomy, then you could wean off sedation and opiates and let him wake up. Would also be easier to do prone position, right? But because he can't have a tracheostomy, because no one will touch him for a tracheostomy if his FiO2s are above 40% and his PEEP is, above, let's just say 10, which is very likely that his PEEP is above 10, right? So I hope that sort of illustrates the lay of the land, what is actually happening there. And because he can't have a tracheostomy at this particular point in time, he's still on all these sedatives and opiates, which then makes it much harder for him to wake up, right? That's number one, makes it much harder for him to wake up, makes it much harder for him to go through rehabilitation. Because, imagine you're lying in bed for 3 weeks, you're not moving anything unless, you get regular good physical therapy, right? It's very difficult to recover and go through rehabilitation. Okay, so then you can continue. He has no advance directive. The hospital is asking, should they do a DNR? Well, the question is, do you want a DNR? What would your cousin want? Are you the power of attorney? Right? Are you the power? Who's making decisions on your cousin's behalf? And given that he does not have a brain injury, well, he should be making this decision himself once he comes out of the induced coma, if that makes sense. Right? So then you continue. They have given a very grim outlook of his quality of life if he survives. Permanently paralyzed, full-time oxygen, relearning life skills, etc. Okay. Will he be permanently paralyzed? Difficult to say. Will it take him a long time to recover and learn to move his arms again, learn to move his head again, learn to speak again, learn to move his legs again, learn to walk again, learn to talk again. Yes, that might be a realistic outlook here, but is that something he's willing to do? Full-time oxygen. Too early to say whether he needs full-time oxygen. Depends whether his lungs will fully recover or not. Right. So he's definitely got a long road ahead. Now, irregardless of that, a very good friend of mine, had ARDS a few years ago, would be about 10 years ago now, and he was in ICU for 3-4 weeks on a ventilator with a breathing tube, didn't have a tracheostomy, but he would have almost been in the same situation. And he came out well, but he needed a long recovery. He needed to go through prolonged rehabilitation. He needed to walk again, needed to learn to walk again, needed to learn to talk again, needed to learn to move everything again. He has been in that situation, right? But, certainly a long road to recovery, but it's doable, right? It's doable. So why would they say this is not brain damaged? So, well, first off, you always have to read between the lines. Okay, you always have to read between the lines what's being said. Why would they say this? Well, I argue your cousin presents their worst case scenario. What do I mean by that? What is an ICU's worst case scenario? An ICU's worst case scenario is to look after patients indefinitely with an uncertain outcome. Your cousin has already been there for 3 weeks, which is a long time, right? In ICU terms, right? The average length of stay in ICU, I believe, is around 2 to 4 days, right? So 3 weeks is a long time in the bigger scheme of things, but for some patients, it's not even a long time. It could just be an average time. It really depends on the situation, right? So why would they say this? Because they want to stay in control of the narrative. So what do I mean by that? They want to stay in control of the narrative because they want to create this narrative of, well, it's all hopeless, it's doom and gloom, your cousin is going to die no matter what, come hail, rain or shine, right? And that's a narrative they want to create. That's the picture they want to paint. And because of that, it's easy for them to say, if he's going to die, well, we told you so. If he's not going to die and he improves, they can look like the hero, right? But why are they being negative? Why are they doom and gloom? And why are they, telling you your cousin's not going to make it, or talk about quality of life, which, by the way, is a perception, no more than that, right? And quality of life depends on perception. And, what is your perception about quality of life? What's your cousin's perception about quality of life? What's acceptable for him? What's not acceptable? Right? Those are questions you need to ask. But to come back to what's their worst case scenario? Well, their worst case scenario is spending a lot of money on someone with an uncertain outcome and dealing with all the emotions that families are going through. They don't want to deal with that, right? By getting someone out and getting the next patient in is so much easier to deal with them. A lot of people, families who watch my blog here, they know that when you have a loved one critically ill in intensive care long term, it's like going down a rabbit hole of issues that you need to break down one by one. And it's very difficult to deal with those issues. This is when our consulting or my consulting and advocacy comes in. And if your loved one is not improving, despite the consulting and advocacy, that's when, services like intensive care at home come in. But they are incredibly difficult issues to deal with. Incredibly difficult issues to deal with. But the question is, there's two things here. If you let your loved one go and you let him die, you know the outcome. Full stop. And I argue if they stopped everything while he's on ARDS, with ARDS in ICU, and is still in an induced coma, there's a very high chance he will die very quickly because of the severity of ARDS as a disease process. And you will see that if you do the research, there's a higher mortality for ARDS patients in ICU compared to other patients in ICU. There's also no question about that. Okay. So come back to the worst case scenario. That is the worst case scenario, right? And they want to stay in control of the narrative. By staying in control of the narrative, it also gives you the illusion, and it gives them the illusion that they can decide who should live and who should die. Well, their job is to save lives. That's their job, right? Is there a risk that he's going to be permanently paralyzed on full-time oxygen and relearning life skills? Absolutely. That is a risk. That is absolutely a risk. But once again, you won't know until you try. You won't know until you try, you know, treating him. It's as simple as that. You won't know until you try treating him. So I hope that answers your questions or your question, you know, and gives you a comprehensive overview on what to expect and what to do. If your cousin has ARDS in ICU, what's the next step? Right? The other thing that you should do if they don't have ECMO in this place, or if they haven't tried prone position, assuming he is hemodynamically stable, he's not on inotropes, he's not on vasopressors, right? You might want to consider getting him to another ICU. You might. You know, you're saying he's in Oklahoma City. Well, hopefully he's in one of the bigger ICUs that have experience, have the skills, have the resources to deal with ARDS. Right? So, I hope that helps and answers your questions. Now, what other questions do you have? Please type your questions into the chat pad or connect with me live on the StreamYard link here. Talk to me directly. I don't bite. You don't have to go on camera, but we can answer your questions so much quicker than if you type them into the chat pad. So let's go to the next question. And if you don't have any questions, that's fine too. Then I would read out some questions, but it is now I'm here. Also, we will be going for an hour. We're 20 minutes, 23 minutes in. We'll be going for an hour. So now is your time to ask questions. Now is your time. Okay, if there are no questions, I want to read out the question from Julie. Julie says, hi Patrick. I have been fighting for my husband for the last 2 years to have a tracheostomy when the time comes. He has MND, also known as motor neuron disease, diagnosed on the 28th of January 2021 at the age of 50. He was admitted into the Austin Hospital in Victoria, in Australia, 3 weeks ago on Tuesday with respiratory failure, pneumonia, and subcutaneous emphysema around the right collarbone. In ER or ED, they asked what his choice was, and it has always been medical intervention to survive. They offered a tracheostomy, and that was escalated so that he could get transferred into ICU up until they called his neurologist. The tracheostomy was cancelled, and he was sent up to a ward where he was placed on BiPAP and a nasogastric tube. And the ward is the long-term weaning ward there, because I know that the place. He was treated for pneumonia and pulled through, and the swelling from surgical emphysema had settled over a few weeks. Unfortunately, he seems to have currently relapsed. The surgical emphysema is back as of tonight, now on both sides of the neck, and his oxygen levels have dropped a week ago. Just for everyone to understand, what is a surgical emphysema? It's basically air under the skin that blows up the skin, right? And especially when the surgical emphysema is caused by a central line insertion, which it sounds like it has been, then you have a really swollen face, right? No x-rays in the past week to see if his lungs have relapsed with pneumonia, and I will push for this in the morning. I have been fighting for him to still be having a tracheostomy in the last 3 weeks. I need to back up. I need all the backup that I can get, help for him at home. Currently, I do all of his care 24/7. I never leave his side, even when we are at the hospital, and still do his full care here. I have no intention of not being by his side, and we're not the normal case of MND in Australia. We are fighting the system and have for the past 2 years. Are you able to help us? Well, of course, absolutely. We're able to help you because, once again, we wouldn't be in business if we didn't help our clients to go from a breathing tube to a tracheostomy to begin with. Because if they can't be weaned off the ventilator, which is most likely the case in your husband's case with MND, it is going to be very difficult to get him off the ventilator without going home or before going home. And yes, it is absolutely possible that we can help you. So how do we go about it? It's really a case of making the case to the Austin Hospital about having the tracheostomy and then moving towards home care, right? That is what we've done for so many of our clients now over the years who've come to us, whether it's in Melbourne, Sydney, Brisbane, Adelaide, all around the country. And soon to be, we will also be starting services in Perth, in Australia and Western Australia. So, it all comes down to the advocacy, understanding from your perspective where our services with intensive care at home come in. Okay, and the Austin Hospital knows our service; they know it very well. So I'm actually surprised they have rejected the tracheostomy, right? But I'm also aware that, and here we are now looking at the bigger picture. MND Victoria in particular is not very supportive of tracheostomies, and they tell their MND clients that they shouldn't have a tracheostomy and that they wouldn't have any quality of life if they went down that rabbit hole. And it's not really a rabbit hole, it's just a case of doing a tracheostomy and then putting the services in place that need to happen at home, right? So we know that MND Victoria, unfortunately, is not very supportive of it. We know that sometimes the Austin Hospital and the BRSS are not very supportive of things, even though they know our service very well. We've been in business since 2012. We started in Melbourne, in Victoria, now going nationwide. So, it's all possible. And talking about MND and tracheostomies in general, there's one prominent case that we looked after that some people know in Australia in particular, Justin Yerbury in Sydney. He had a tracheostomy for many years with MND, and it was all doable for him to live at home with that. We have another MND client in Victoria that's been at home with a tracheostomy with 24-hour critical care nurses since late 2019, and is very happy to be alive, right? He's very happy to be alive. And people should absolutely honor their wishes. There's another tracheostomy client in the community in Melbourne, in Victoria, where we're also involved in the nursing care with critical care nurses. This lady is in her 60s. She also wants to live. So for MND Victoria, or for anyone, whether it's the Austin Hospital or for the BRSS, to make judgments about who should and who shouldn't have a tracheostomy, especially with NDIS funding critical care nurses in the home 24 hours a day for MND patients, is just not appropriate. And it goes against patient autonomy. It goes against patient wishes, right? And that is very disrespectful, quite frankly, right? We are here with intensive care at home to create choice for patients and families, and hospitals should do the same. MND Victoria should do the same. The other thing that I found with MND Victoria, very few people there are clinicians, from what I've seen. Just looking at who's working there, very few of their people at MND Victoria are actually clinicians. So how can they guide patients with MND if they're actually not clinicians and know what care needs to be put into practice? And what we've also seen is that MND Victoria cannot always advocate for the right level of funding. We've also seen that because we have been involved in the advocacy for the right level of funding for our clients. right? So, Julie, so the next step really is we need to sit down with the hospital, and we need to sit down, and once again make them aware of what's possible in the community. And they know about those M&D clients in the community. They do, with tracheostomies. And also for context there, Julie, once again, some of you know that I have done intensive care at home work in Germany way back when, and we were looking after M&D patients in the community with tracheostomies in Germany, right? And that's 25 years ago, or 25 years ago. And that means Australia or M&D Victoria, and maybe even the Austin Hospital, is 25 years behind. You got to open your eyes. You got to give people choice and not belittle patients about their choices, or make judgments about people's choices, because it is their choice, not your choice. Now let's also talk about what else needs to happen if your husband has a tracheostomy. He also probably needs to have a PICC tube, right? They often do go hand in hand. And just in case you're wondering, why am I saying he needs to have a PICC tube in this instance? Because sometimes on this channel I say, don't do a PICC tube, and I tell you the difference. Don't do a PICC tube if someone needs short-term ventilation. Unfortunately, Julie, if your husband ends up with a tracheostomy with M&D, he won't be short-term ventilated. Unfortunately, he will be long-term ventilated, right? Because he will be long-term ventilated with no outlook of being weaned off the ventilator, right? At this particular point in time, he will need a PICC tube, right? So, where to from here? He needs an urgent review of his NDIS plan, because I know he's got an NDIS plan, right? And also for anyone watching this, if you are in a similar situation, you need to start with the advocacy right from the get-go. But you also need to start with the advocacy with someone that understands this area. And I do believe that I am understanding this area inside out, right? And you need to advocate correctly. You need to have services in place, and you also need to have funding in place. Now, that leads me actually to NDIS legislation. Now, over the last few months, we have been doing a deep dive into NDIS legislation, right? And we have actually sought legal advice about it. So basically, our question was whether, if we as clinicians, i.e. critical care nurses, deem that a client is at risk without 24-hour critical care nurses, who's actually taking responsibility here? Now, and because we sought legal advice about it, right, we actually found out the NDIS is actually responsible for that. But also we as a provider, which is something we didn't know either. So we are constantly learning as we go along. And I actually want to go to the letter from the legal advice that we sought. So I'll just read that out. So what we were basically looking for with NDIS funding was whether the NDIS can provide funding for emergency care even though it's not in an NDIS plan. Right? Let's just say there's rapid deterioration for an NDIS participant, and the deterioration is secondary to their disability. It is not health related. It is secondary to that disability. I'll give you an example. We had a client recently who was at home with cerebral palsy, and the client was ventilator dependent on BiPAP, no tracheostomy, but was on 5 to 15 liters of oxygen on BiPAP with cerebral palsy, with intermittent seizures, with the PEC tube and the patch tube, right? And when we first started that, we realized, oh, this is actually an intensive care at home client, because if the client is not having 24-hour critical care nurses, the client would die, right? So we as clinicians can identify that. We as clinicians, we are APRA registered with, the government authority. We can't make things up, because if we did, we could lose our registration or license. So there's checks and balances, actually. We can't just make things up. But regardless of that, we actually had an independent nursing assessment from a critical care nurse with a legal nurse consulting background. So, with that risk identified, the question that we had to the lawyer is there a legislative basis for us to say to the NDIS, well, from tomorrow, from now, we need 24-hour critical care nurses to keep this client alive? And it's secondary to their disability, it's not a healthcare issue, right? The healthcare issue is secondary to their disability. That's when the NDIS legislation is really kicking in. So here's what the lawyer says. It says there is legislative basis for intensive care at home to claim from the NDI when the plan has been exceeded, if payment is necessary to prevent or lessen an imminent threat to an individual's life, health, or safety. Very simple. Very simple. Now, here's a little bit of a caveat, but however, seeking a reimbursement is ultimately at the discretion of the CEO of the NDIA, so there's no guarantee that this payment will be made, even if the care does meet this criteria. Given the type of service you are providing, it is likely you will be able to get a reimbursement. However, there will always be a risk. When a risk is identified, and this is a clinical risk, and time permits, you should encourage the participant or their authorized representative to at least apply to seek a variation to the NDIS plan. If your staff have doubt about whether the supports being provided would satisfy the NDIS, intensive care at home should consider reaching out to the NDIS as a matter of urgency, which is something we have put to the test now. It is something we have put to the test in the last couple of months, and so far it is clear that NDIS legislation is supporting this approach, right? So I will say this, as much as I have said negative things on this channel about the NDIS, I will say this: part of it has been by us not fully understanding legislation, but someone has made some suggestions to us to look into NDIS legislation, which we've done now, and clearly the strategy is working. So we have to a degree been flying blind about NDIS legislation for a number of years, which is only our fault. But we have put this strategy to the test. So anyone watching this who has a family member either in hospital, in ICU, or has a family member at home and is realizing that you want to go home, but you don't have the support in place, you think you don't have the funding, or if you're at home already and you think, oh, I need more funding, right? There is a way. Clearly, there is a way. We have tested this now with a number of clients with much success. As long as there is clinical justification, right, that the need for nurses, critical care nurses, registered nurses, to keep a client at home and have choice and control, the NDIS will pay, right? So that is such good news. And it also goes to show that, as much as I have said on this channel publicly, that the NDIS has a long way to go and has a lot to improve. It is actually not out there to get people. It is actually there to support people, and it is actually there to free up hospital beds. It's there to free up ICU beds, right? The legislation is actually very supportive of that. But like I always say, you don't know what you don't know. And then it's your job to find out what you don't know, right? So that is really good news across the board, that finally, there is funding for the right clients. And there always has been funding for the right clients, but now we can access funding much quicker, right? The other advice that we had was obviously, ideally, nursing assessments should be done by independent practitioners, of course. We are trying to do that. But I can also tell you that sometimes there simply isn't any time to find an independent practitioner to do nursing assessments. So in the meantime, we do the nursing assessments ourselves. And one could argue conflict of interest, but straight away I will say, well, we are APRA registered, right? And APRA is the regulatory body, right? Which means that the overseeing body here is actually APRA, not so much the NDIS, right? So there is a clear pathway now for moving forward with NDIS participants that need critical care nurses, which includes your situation, Julie, today, that we've discussed at length now, right? So I hope that helps you understand what's happening in the NDIS space, especially when it comes to intensive care at home clients. Okay. Another example that I want to bring up today is, while we are talking about intensive care at home, recently we've been asked to go into a SEAL facility, and a SEAL is an NDIS supported independent living facility, and we are looking after a client in there where we go in there once every 4 weeks to change an IDC, an indwelling catheter. Now, it turns out that when we were going in there for the IDC change, or one of our senior staff was going in there for the IDC change, it turns out that this client also happened to have a tracheostomy, right? And when we saw that, obviously we couldn't believe it, because the client was basically in their room at the SEAL facility and no one was there. Now, a tracheostomy client in the community, especially a tracheostomy client with an ABI, she has an acquired brain injury, right? And her Glasgow Coma scale is rather low. It's about a 5, which means, you know, she's pretty close to a vegetative state, which means her airway is at risk of collapsing at any time. Her airway obstructing and her dying is a huge risk for someone with a tracheostomy, especially if they can't get help, if they can't alert themselves, right? So huge risk here. So, and this comes down to non-clinical providers providing care that they shouldn't be providing. And that's where the checks and balances of the NDAs are really poor. How can a tracheostomy client end up in a SEAL facility with no 24-hour nursing care? That is rather dangerous and puts this client's life at risk. And she's only 35 years of age, right? It's an absolutely shocking situation, but this is what happens when, you know, SEAL providers or other NDS providers have no to little clinical governance. But it's also that we're finding the NDIS has very little clinical governance, right? There needs to be clinical governance. Okay, so let's look at another email from Jonathan, who says, "Hi Patrick, my mother has been in ICU since January the 20th, 2025 with ARDS and was treated with antibiotics for UTI, blood infection and pneumonia. She's been on the ventilator from the first day for low oxygen levels and high CO2. She's comorbid with 2-stage 4 pressure ulcers on her back. She's got dementia, and she's got third space fluid buildup in several locations. The ICU team does breathing tests each day to extubate, but hasn't seen good responses. About 5 days ago, she went for 8 hours breathing. The next day, 6 hours, and the past 2 days are less than a minute before she's going back to assisted ventilation breathing. She's awake, eyes open, not appearing in pain, and blood pressure, pulse, oxygen, and testing has somewhat stabilized electrolytes, but full blood count results indicates weak red blood cells levels. No plasma has been given, which is probably also why she's third spacing, because if she's got third space fluid buildup, the albumin is probably low, or her red blood cells are low. Maybe a combination of both. I am reluctant to remove the ventilator yet, in hopes she would regain the desire to inhale on her own, but they say dementia likely is causing brain signals to be weak for stimulating diaphragm to take breaths, since eyes open and she's salivating and is responding to my touch. Or if I do suctioning, I know that she's still aware enough to see me, etc., but I can't communicate to be sure of much more. The doctor says outlook is poor and pain may exist, but we can't tell, as the tube prevents vocalizing sounds to convey this. I've been pushing back on their wish to limit or eliminate ventilation support and terminate because of the 10 to 14-day limit. They say ventilation usually follows for a successful outcome. The backstory: 8 months ago, she was in the same ICU, 6 days on the ventilator, and recovered to home care and baseline within a month. Thus, ultimately, we might win a battle, but won't win the war, as it won't make her live much more. In my mind, I'm willing to hold off on the 14-day warning so long as I see her awake and she's interacting with me. As I'm the only child caregiver and proxy, I will have to make decisions and be her advocate, as I've done for the 4 years, as she's got dementia and other medical issues like pressure ulcers won't care. It's not going to be easy to let her go. I've been reading through your online materials, trying to grasp at straws of optimizing for a possible turn of events, getting her off the ventilator even after 11 days on it now. I feel like I'm backed into a corner of suffering while I resist the doctor's advice to go with morphine and removing ventilation support. What do you think about doing a tracheostomy after 14 days and then looking at home care options? I am sure there's a lot more to consider, but I am overwhelmed with the idea I'd be pulling the rug out when she may regain the strength or brain signals to get back to breathing without the ventilator, or having the tracheostomy and then go home. Thank you for your side and your time. From Jonathan. Well, thank you, Jonathan, for giving such a detailed explanation of your mom's situation. Well, bottom line is this: yes, you shouldn't be waiting for more than 10 to 14 days before consenting to a tracheostomy. But the problem here is, what you haven't shared with me is, are they trying to do everything beyond the shadow of a doubt to get your mum off the ventilator and the breathing tube? What are they doing to avoid that tracheostomy? It sounds to me like she was doing well, and then she stops breathing for whatever reason. Is that because they're putting her back on the ventilator, on sedation, on opiates? What are they actually doing? Right? So what would she want? Right? Also, you're saying 8 months ago she was in the same ICU, 6 days on the ventilator and recovered to home care and baseline within a month. Well, that why can't that happen again? Let's just say, right? So, you have some options here. A, she'll get off the ventilator, but they will need to do the right things here, and it doesn't sound to me like they are. Right? B, you have the option of a tracheostomy and a PEG tube, or a tracheostomy and a nasogastric tube, and then she can go home with intensive care at home, of course. Right? And you should also approach it that way with them if that's what you want. Right? Give them options, so you're not held hostage to only their options. Right? So, you know what's going to happen if you go down the track of, giving her morphine and removing ventilation support. That could be perceived as euthanasia. The definition of euthanasia is to hasten death. Euthanasia and hastening death is still illegal. Keep that in mind. They're basically suggesting something illegal to you, but they think they can get away with it. Right? The other question is, I think we didn't mention anything about an advanced care plan. So my question to you is there an advanced care plan? Because if there isn't an advanced care plan, what would your mum want? If there is an advanced care plan, it would be documented what your mum wants. But these are the challenges in those situations, Jonathan, that people don't know what their family members want because it hasn't been discussed, you know. So, you know, for anyone watching this, it's good if you have an advanced care plan so that you know what to do in a situation like that. You know, you say you're pressured daily to let her go peacefully with pain management to start before they remove the ventilator, and they say she will likely pass within hours. You know, once again, that brings me back to euthanasia, because that's what, in my eyes, that's what describes euthanasia, right? Also, the ICU doctor says risk of ventilator-associated pneumonia or other issues with current poor health are not surmountable and increase daily if on a ventilator. Okay, let me break this down for you. The risk for a ventilator-associated pneumonia when someone is ventilated either with a breathing tube or with a tracheostomy is real. Okay, that's a reality. So you could then say that anyone going into ICU on a ventilator is at risk of ventilator-associated pneumonia, and they are. There's enough research out there to back that up. Does that mean we stop ventilating because there's a risk of ventilator-associated pneumonia? That's like saying we stop breathing because there's a risk air is contaminated. That's like saying we stop eating and drinking in case food or water is contaminated. Right? So, and you're saying you're pressured daily. Well, you're not pressured, you're just responding with that. You need to make, I mean, that's just your choice how you respond. How you respond to perceived pressure, that's your choice. Don't blame them. Just make sure that you are in control of how you respond. That's all you need to do here. Right? And let's just say your mum can't survive for whatever reason and she has a tracheostomy. I'm sure you'd rather have her pass away at home than in an ICU where you don't feel respected, where you feel like your wishes are completely ignored, where all they want to do is talk about end of life and talk about the risk of ventilation. Don't get me wrong, no one wants to be ventilated, no one wants to be at risk of a ventilator-associated pneumonia, but no one wants to be at risk of dying either. You've got to weigh up your options here, because you do have options. You just need to present them in the right way. And I guess what you have as a baseline is that 8 months ago, she was in the same ICU and she recovered back to baseline. What I can see in your email is she's on too much sedation. She's on too much sedation, and that might be why she's not breathing. And keep in mind, the longer someone is on a ventilator with a breathing tube on sedation, the higher the chances are they will need a tracheostomy. So that's why I'm saying, what are they doing beyond the shadow of a doubt to get her off the ventilator? To get someone off the ventilator beyond the shadow of a doubt, you've got to stop sedation, you've got to stop opiates, you've got to get people onto physical physiotherapy as quickly as possible, got to get them onto breathing exercises as quickly as possible, which might be challenging for your mom because she's got dementia. She's got dementia. So I hope that helps you understand, Jonathan, of what the next steps are, but also keep in mind, because I know the question is always coming, who's funding home care? Keep in mind, someone's funding an ICU bed, and someone's funding an ICU bed for $5,000 to $6,000 per bed day. Let that sink in. $5,000 to $6,000 per bed day. Intensive care at home is half of that cost. Right? Someone, whoever's paying for that ICU bed, will have a genuine interest to fund half of the cost. I can assure you of that. There's an economic argument in there. There's a business case in there. But more importantly, there's a human case in there. There's a human aspect in there. Right? There's a strong human aspect in there. And ICUs want their beds. The ICU bed is the most sought after bed in a hospital, right? The most sought after bed in a hospital is the ICU bed. And, you know, ICUs have an interest in emptying that bed. But their way to empty that ICU bed is by trying to, quote unquote, sell you on end of life and euthanasia. Just something for you to think about. So I hope that helps you. But also, what I can see from your email, Jonathan, there, if she does go home, her health status needs to be optimized, i.e. she will need some albumin, she will need some blood transfusions by the looks of things, so she's stopping, you know, so the third spacing is stopping and all of that. You know, some optimization has to be done while she's in hospital. But other than that, as long as she's hemodynamically stable, there should be nothing stopping her from going home. Nothing. Okay. I'm going to wrap this up in a few minutes. Are there any other questions that you want to have answered quickly? If you do, then I encourage you to type them into the chat pad. Once again, if you do like my videos, you know, subscribe to my YouTube channel for regular updates. You also get the notifications for the YouTube Live. Click the like button if you like this video. Click the notification bell. I also encourage you to share this video with your friends and families who might need it. And comment below so I know what content you want me to create, what you want me to address, what questions you want to have answered. Because, you know, the content that I'm making is really driven by the people that I'm talking to and by the emails that I'm getting, the phone calls that I'm making or getting. You know, it really comes down to that. It's all user driven, all client centric. Right? The hospitals put content out there that's hospital centric. They don't want you to know their secrets, whereas I'll give you their secrets here. I've worked in hospitals long enough to know their secrets. Okay, so once again, if you have a family member in intensive care and you need consulting and advocacy, go to intensivecarehotline.com, call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com. I do one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. I talk to doctors and nurses directly. I talk to you and your families directly. I handhold you through this once-in-a-lifetime situation that you simply cannot afford to get wrong. We also do medical record reviews in real time so that you can get a second opinion in real time. We also do medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. We also have a membership for families of critically ill patients in intensive care. And you can become a member if you go to intensivecarehotline.com, or click on the membership link, or if you go to intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related. With intensive care at home, like I said, go and check out intensivecareathome.com. We're currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas. We are NDIS approved all around the country, DVA all around the country, TAC and WorkSafe approved in Victoria, iCare in New South Wales, NIISQ in Queensland. We are providing level 2 and level 3 NDIS support coordination. We are also providing TAC case management, TAC and WorkSafe case management in Victoria. We are providing a genuine alternative to a long-term stay in intensive care with intensive care at home. And like I said, we're providing tracheostomy ventilation management, BiPAP, CPAP ventilation at home, Hickman's line, PICC line, central line, portacath management, nasogastric tube, PEG tube management at home, ventilation weaning at home, as well as palliative care at home. Thank you so much for watching. Thank you for your support. Have a wonderful week ahead, and I'll talk to you again next week. Take care for now.